Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Imagine a closed-loop obstruction right down in the pelvis. I mean, the pressure inside that isolated segment of bowel is just, it's skyrocketing by the minute.
Oh, absolutely. It's terrifying.
Right. Arterial blood flow is getting choked off. Ischemia is setting in. You've got this ticking time bomb, and your absolute first instinct to just rush into the operating room and cut it out, well, that might be exactly what kills the patient.
Yeah, it's the exact opposite of what you should do.
For the surgeons and the frontline doctors listening to this deep dive right now, you know that there are, well, very few clinical scenarios that spike the heart rate, quite like a high-stakes bowel obstruction caused by a rectal stricture.
For sure.
Managing this requires a fiercely specific, really mechanistic approach. But before we get into the surgical weeds, I must state clearly up front, this content is for reference only. Always follow local guidelines in your own clinical practice.
Right, because the human pelvis is, well, it's a high-rent, incredibly unforgiving anatomical district. I mean, while the literature gives us a roadmap, the reality of the tissue you actually encounter on the ground, it's totally unpredictable.
Definitely.
So our mission today is to distill this massive stack of clinical literature into a functional, evidence-based pathway for managing these strictures. We want to take you all the way from the chaotic emergency room presentation to definitive, elegant surgical resolution.
And reading through these sources, the whole process actually reminded me of a hostage negotiation.
Oh, I like that. How so?
Well, you don't just breach a building with guns blazing the second you arrive, right? You secure the perimeter, you stabilize the immediate threat, and you gather intelligence on who is inside.
Right, right.
Then you start negotiations, which clinically would be our minimally invasive endoscopic techniques. It is only when those negotiations completely break down that you call in the tactical team and escalate to formal surgery.
That's a perfect analogy, because jumping straight to the tactical team is how you end up with just catastrophic complications. I mean, if you don't secure the physiological perimeter first, your definitive surgery is, well, it's doomed before you even make the incision.
Wow, really?
Yeah, the literature is totally unanimous on this. Before you look at the anatomical clumping, you have to assess the systemic collapse.
Let me stop you right there, though, because, and I think this surgical urge to fix a mechanical problem with a mechanical solution is just overwhelming.
Oh, it's ingrained in us.
Exactly. You see a physical blockage on a CT scan, and every instinct screams to decompress it immediately. I mean, if a patient comes in obstructed, but their electrolytes are a mess and they are severely hypovolemic, my brain says, fix the blockage and the physiology will follow.
Right.
So why is the literature telling us to hit the brakes and hydrate them first?
Because of the microvascular reality of tissue healing. So think about it. When a patient is severely dehydrated from third spacing fluids into their dilated bowel, they are hypovolemic. The body responds by shunting blood away from the splanchnic circulation, the gut, just to protect the brain and the heart. The microvessels in the bowel wall clamp down.
Okay, so they're completely clamped.
Exactly. So if you rush that patient into the OR, cut out the stricture, and sew the two ends of the bowel back together right then, you are creating an anastomosis in a severely hypoxic, underperfused environment.
Which means it's not going to heal.
Not a chance. Without adequate blood flow and oxygen delivery at the cellular level, those tissues just cannot produce the collagen matrix required to seal the connection. The anastomosis will fail, it will leak, and you will induce overwhelming pelvic sepsis.
So prioritizing fluid resuscitation and correcting potassium and sodium, it isn't just medical housekeeping. It is the literal prerequisite for your suture line actually holding together days later.
Precisely. It's foundational. And this assessment phase is also where you determine your exact timeline by ruling out a closed-loop physiology.
Right.
I mean, a simple obstruction is bad, but a closed-loop obstruction is a completely different physical phenomenon.
Because it's blocked at 2 points. Like a closed loop is where the bowel is obstructed at the stricture distally, but also closed off proximally. Usually by a competent ileocecal valve. Right. That won't let contents reflux back into the small intestine.
Exactly.
So you trap gas and fluid with absolutely nowhere to go.
And the physics of that situation are brutal. According to Laplace's law, as the diameter of that trapped bowel segment increases, the wall tension increases exponentially.
Oh, wow.
Yeah, so the rising pressure inside the lumen quickly surpasses the pressure of the venous blood trying to drain the bowel, so the veins get compressed and they just shut down.
But the arteries keep pumping.
Right. The arteries, which have higher pressure, they keep pumping blood in, so the bowel wall rapidly swells with trapped blood and edema until the pressure is so high that even the arterial inflow is choked off.
And that is mucosal ischemia. The
Mm.
tissue literally starts suffocating and dying.
Exactly. And once ischemia sets in, the barrier function of the gut wall breaks down. You get massive bacterial translocation, followed rapidly by frank perforation.
Which is a total nightmare.
It is. In a closed-loop scenario, you no longer have the luxury of prolonged conservative management. The physiological perimeter is actively collapsing.
Okay, so let's say the physiological fire is out. It was just a simple obstruction. The vitals are stable, they're hydrated, and the tissues are perfusing.
Good.
But you are still staring at a blocked tube. So the objective now shifts from keeping the patient alive to figuring out the exact nature of the wall of that tube. Because the etiology, what that stricture is actually made of, that changes the entire surgical playbook.
You must know the enemy before you engage. And the fundamental division in the literature here is determining whether you are looking at a benign fibrotic scar or a malignant tumor.
Right.
The workup relies heavily on cross-sectional imaging with contrast, flexible endoscopy, and crucially, obtaining tissue biopsies.
Wait, hold on. If I'm looking at a scan,
Yeah.
and it is clearly the exact site of a prior low anterior resection, my brain immediately says, well, this is a standard anastomotic stricture.
It's a natural assumption.
Right. It's just scar tissue from the staple line.
Is the risk of a sneaky malignancy really high enough to delay relieving the obstruction just to wait for pathology results from a biopsy?
The danger of assuming a stricture is a benign scar cannot be overstated. A local malignant recurrence does not always present as a massive, obvious, cauliflower-like tumor growing into the lumen.
Okay.
Cancer cells can migrate and proliferate within the submucosal layers or even along the extraluminal planes of the old surgical scar.
Oh, I see.
So from the inside, on a standard endoscope, it might look like a totally smooth, simple, benign fibrotic ring.
And if you assume it's benign and just try to force a balloon dilator through it?
You could split a tumor wide open.
Wow.
Yeah. You risk causing a free perforation, seeding malignant cells throughout the entire pelvic cavity, and just severely compromising the patient's long-term oncological survival.
That's devastating.
It is. Plus, the tissue history is critical. You must investigate whether the patient has a history of pelvic radiation. Irradiated tissue is not just scarred, it is fundamentally damaged at the cellular level. How so? I mean, isn't radiation fibrosis just a tougher version of a normal scar?
Not at all. Radiation induces something called obliterative endarteritis.
Okay.
The tiny blood vessels that feed the rectal wall are permanently scarred shut, and the local stem cells and fibroblasts are totally depleted. Irradiated tissue is chronically ischemic. It just lacks the biological machinery to repair itself.
So it won't heal.
Right. If you attempt a definitive local surgical revision on irradiated tissue, assuming it will heal like normal bowel, it will simply crumble and leak. You are operating on a biological desert.
That is a terrifying image, but it highlights exactly why the biopsy and the history are vital intelligence. So, let's assume the intel comes back favorable. The pathology is benign, there's no radiation history, the stricture is relatively short, and it's reachable.
The best case scenario.
Right.
Right.
This is where we initiate the negotiations. We intervene, but we start with the absolute least invasive options to spare the patient the massive physiological hit of a redo pelvic surgery.
Absolutely. For stable patients with short, benign strictures, the literature overwhelmingly supports endoscopic or transanal treatments as the first line of defense.
And the heavyweight champion in this category seems to be endoscopic balloon dilation.
Yes, very common.
You slide a deflated balloon through the scope, position it across the stricture, and pump it up with water or contrast to stretch the ring open. But the sources are very clear that this isn't a magical one-time fix.
No, it rarely is.
I actually came across an analogy thinking about this. A fibrotic stricture is basically like a heavy-duty plastic zip tie pulled tight around the bowel. Drugs and time won't dissolve plastic. You have to physically stretch or break it.
Okay, I like where this is going.
But an inflammatory stricture, one that is actively inflamed from recent surgery or infection, is like a severely sprained, swollen ankle.
Huh. That is a brilliant way to conceptualize the pathology. Because if you try to violently stretch a swollen, inflamed ankle or an inflammatory stricture with a high-pressure balloon, you are just going to cause massive traumatic tissue tearing.
You'll just make the swelling worse.
Exactly. Inflammatory strictures need to be managed conservatively. They need bowel rest, time, and anti-inflammatory medications to cool off before you even touch them.
But with the zip tie, the dense, mature fibrotic scar. You have to apply mechanical force.
You do.
But why does the literature say balloon dilation requires so many repeated sessions? I mean, why can't we just inflate a massive balloon, stretch it completely open on day one, and just be done with it?
Because of the molecular structure of the scar, a benign stricture is a dense ring of cross-linked collagen fibers. When you inflate the balloon, you are physically tearing those hydrogen bonds and causing microfractures in the collagen matrix.
Right, microfractures.
So if you try to stretch it to a normal diameter all at once, the microfractures become a macro rupture, and you perforate the bowel wall.
So it has to be incremental.
Yes. You stretch it a few millimeters, inducing controlled micro tears. The body then heals those micro tears, remodeling the collagen slightly wider than before.
Ah, I see.
A few weeks later, you go back and dilate it a bit more. You are gradually tricking the fibrotic ring into remodeling itself into a wider diameter through sequential controlled trauma.
And if the balloon isn't cutting it, the literature suggests stepping up the aggression with strictureplasty. You can use electrocautery to physically slice into the fibrotic ring in multiple quadrants to break the tension, or even use a transanal circular stapler to punch out a new, wider lumen.
Those incision-based techniques can be highly successful, yeah, but they demand a very specific anatomy.
Like what?
The stricture must be low enough in the rectum to reach safely, and the surrounding tissue must be healthy and compliant enough to tolerate being cut or stapled without completely falling apart.
This brings me to something that really caught my eye. If we have a narrowed fibrotic tube, why not just drop a stent in it? I mean, we put stents in clogged coronary arteries every single day. We use them in bile ducts. Why does the literature practically scream that endoscopic stenting is a terrible idea for benign rectal strictures?
It seems counterintuitive, I know, until you look at the physical environment of the rectum versus a blood vessel. Stents work beautifully in malignant bowel obstructions.
Okay, why?
Because a tumor is a rigid, irregular, bulky mass. When a self-expanding metal stent deploys inside a tumor, the jagged cancer tissue grips the mesh of the stent.
Oh.
Yeah, the stent uses the tumor as a scaffold to lock itself firmly in place, forcing the lumen open.
Ah, but a benign stricture is completely different tissue.
Exactly. A benign stricture is usually a smooth, slippery, fibrotic ring. So once the stent expands and forces that ring open, there is no jagged tissue to hold it in place. The stent simply slides down and falls out. The migration rates in benign disease are astronomical.
Not to mention the sensory experience for the patient. The lower rectum is exquisitely sensitive. I mean, it is wired to detect pressure and stretch to tell the brain when it's time to find a bathroom.
Right. So having a rigid metal cylinder constantly pushing against the somatic nerves of the lower pelvis causes severe tenesmus.
Which is that constant agonizing feeling of needing to empty your bowels.
Yes, along with chronic pelvic pain. And even if the stent stays in place, it almost never permanently resolves the dense collagen fibrosis. You eventually have to go back in to retrieve the stent or manage the tissue ingrowth.
So it's not a fix at all.
No. So while stenting is an incredible bridge to surgery tool for cancer, in benign strictures, it is an absolute last resort temporary measure.
The environment dictates the tool. But what happens when the negotiations completely break down? The zip tie refuses to stretch, the anatomy is severely distorted by radiation, or the patient starts showing signs of ischemia.
Then you pivot.
Right. This is where we change the strategy entirely. We move away from the endoscope and call in the tactical team formal operative surgery.
When local therapy fails or is anatomically impossible, you must escalate. And quite often, the safest, most strategic first step in that escalation is creating a defunctioning stoma, like a loop ileostomy or colostomy.
And the literature outlines a few scenarios where a stoma is vital. Right? Urgent decompression of a highly distended bowel, managing frail septic patients, or when the pelvic anatomy is just too hostile to traverse.
Exactly.
But let's talk about the surgical mindset for a second. Surgeons are trained to resect, to restore continuity, to cure the primary problem. Walking away from an operation, having only created a stoma, can feel like a clinical defeat, like you didn't actually fix the stricture. Shouldn't we reframe how we view this?
Absolutely, because viewing a stoma as a defeat is a really dangerous ego trap. What we are talking about here is the principle of damage control surgery.
Okay.
When a patient has a severe neglected obstruction, their entire pelvic cavity is a bloody edematous swamp. The tissues are inflamed, swollen, and incredibly friable. I mean, they tear like wet tissue paper if you try to put a suture through them. Operating in that acute inflammation is a blind gamble.
So a defunctioning stoma is hitting the ultimate biological pause button.
It is a brilliant tactical maneuver. By bringing a loop of healthy bowel up to the skin and diverting the fecal stream completely away from the stricture, you immediately resolve the life-threatening mechanical obstruction.
The proximal bowel decompresses.
Yes. The systemic inflammatory cascade shuts down. You give the inflamed, swollen pelvis weeks or months to cool off and return to normal anatomy.
So you convert a chaotic midnight emergency into a controlled, well-lit elective surgery 3 months later, when the patient is nourished and their tissue can actually hold a stitch.
Precisely. That is not a defeat. That is surgical mastery.
But eventually, the pause button has to be unpaused. Definitive formal resection is indicated when malignant strictures are confirmed, when those non-invasive balloon dilations fail repeatedly, or when a patient simply cannot tolerate the disabling symptoms anymore.
Right.
The interventions range from local redo anastomoses all the way to major anterior resections or a permanent end colostomy, depending on how badly the pelvic floor is damaged.
And we must reiterate that formal surgery is mandatory. I mean, there is no negotiation if you encounter complications like perforation, irreversible ischemia, or uncontrolled hemorrhage.
Yeah, obvious.
If the bowel is dying, you must resect.
However, the texts explicitly warn that for benign, uncomplicated strictures, a major pelvic resection should remain your absolute last resort.
Always.
The minimally invasive approaches the balloons, the transanal strictureplasties carry significantly lower morbidity. You don't risk major nerve damage, life-altering bowel dysfunction, or catastrophic anastomotic leaks by doing a massive pelvic dissection if a simple balloon could have safely remodeled the scar tissue.
Right. You never use a tactical strike team to handle a situation that could have been resolved with a phone call.
That's a great way to put it. So, how do we synthesize this immense amount of pathology, physics, and clinical judgment into a usable framework for the clinician standing in the emergency department?
Let's break it down.
The sources effectively build a concrete 5-step battle plan. Let's walk through it. Step 1. Resuscitate and assess severity. Do not touch the blockage until you have restored microvascular perfusion with IV fluids, corrected the electrolytes, and aggressively ruled out the ticking time bomb of a closed-loop obstruction or frank ischemia.
Step 2. Gather your intelligence. Confirm the precise anatomical level of the stricture and determine its biological etiology. Get your contrast CT, perform flexible endoscopy, and absolutely secure tissue biopsies to rule out a masquerading malignancy or radiation damage.
Step 3. If the stricture is confirmed, benign, short, and accessible, start the negotiations. Attempt endoscopic balloon dilation as your first-line therapy, remembering that remodeling collagen takes multiple incremental sessions.
Step 4. If the balloon dilation fails to yield durable results, or if the stricture geometry is highly complex, escalate to local transanal therapies. Consider precise electrocautery incisions or stapled strictureplasty to mechanically break the fibrotic ring, provided the surrounding tissue is healthy enough to support it.
And finally, step 5. If the stricture remains obstinately blocked, is anatomically unsafe to dilate, or proves to be malignant, you escalate to formal surgery. You perform damage control diversion with a stoma, or you proceed with definitive surgical resection.
Perfect.
And if you remember nothing else from this deep dive, remember how to match the tool to the tissue. Anastomotic scars respond to the mechanical stretch of balloons. Inflammatory strictures are sprained ankles that need time and medical management to cool off. Dense fibrotic strictures are plastic zip ties that require mechanical disruption or surgery. And malignancies are treated as cancer, full stop.
Recognizing the biological reality of the tissue you are looking at, understanding why irradiated bowel crumbles and why fibrotic collagen needs micro-tearing is what elevates a competent technician into a master surgeon. It is applied biology in real time.
It really is. We have spent this entire deep dive discussing how to mechanically bypass, stretch, or resect these rectal strictures once they are already causing havoc in the pelvis. It is a masterclass in reactive problem solving. But for the surgeons listening, I want to leave you with a final thought to mull over, something that pushes beyond crisis management.
Oh, I like this.
The next frontier is true prevention. How do your specific minute-to-minute decisions during the very first surgery influence the creation of these strictures? Think about the tension on your staple lines. Think about your meticulous preservation of the microvascular blood supply to the rectal stump.
Right, the initial insult.
Every stitch that pulls a little too tight, every vessel that is needlessly sacrificed contributes to local tissue ischemia, which ultimately drives the excessive fibroblast activity that forms these benign strictures in the first place. It is something to seriously ponder the next time you are deep in the pelvis forming an anastomosis.
Because the safest, most elegant way to manage a severe rectal stricture is to ensure your initial surgical technique never gives it the biological excuse to form.
Absolutely. Well, that wraps up our analysis of this complex clinical pathway for today. If you like this content, please don't forget to share this deep dive with at least one of your colleagues or friends to help spread the word. We want this knowledge reaching as many frontline clinicians as possible.
And check out our YouTube and other social media pages for more clinical breakdowns and visual discussions of these topics.
Also, do check our previous season and episodes which cover some very relevant surgical and medical topics that you won't want to miss. Thank you so much for joining us. Keep up the fantastic work on the wards, and we will catch you on the next deep dive.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.